So thank you everybody for joining this evening. My name is Dr. Alex Puidapam with IR Centers, and thanks for Dr. Ogilvie for putting on this webinar here to talk about BPH. I think it's a novel treatment that we can offer to the community that's less invasive with really great outcomes, and I think we're excited to share that with you all tonight. Without further ado, we can kind of move forward. So interventional radiology, and what is interventional radiology? Because you might be thinking, well, BPH and my prostate, why would I go see an interventional radiologist? But really an interventional radiologist like Dr. Ogilvie, they're the minimally invasive specialists. So the push nowadays with innovation and really care in general is to try and implement the best therapeutic outcomes with the lowest amount of risk and the lowest amount of downtime. And that is right in the interventional radiologist warehouse. So basically, or wheelhouse, we use minimally invasive procedures or technique with the aid of image guidance, whether it's ultrasound or live x-ray or fluoroscopy, to guide us. And through this tiny little needle hole or pinhole, Dr. Ogilvie is able to implement this amazing treatment for patients. So IR Centers works closely with the urologists, the Central Ohio Urology Group, or COOG, to provide these procedures. It's easier than the hospital. You're in and out in one day, just really a few hours, fast recovery, not much downtime, and it's personalized concierge care that you're not really going to get anywhere else in the area. This is the address for the office, and we'll keep that information up at the end as well. So to speak on Dr. Ogilvie, he's a good friend of mine. I think you guys are really lucky to have him back in the community. Originally from Cincinnati, Dr. Ogilvie completed his undergraduate studies at Denison University in Ohio, where he majored in physics. So you can tell he's a bright guy. Attended medical school at University of Cincinnati College of Medicine, then completed his diagnostic and interventional radiology training as part of the IR or interventional radiology residency program at Henry Ford in Detroit, Michigan. And there he served as chief resident. So those of you who don't know, it's a pretty distinguished honor where you're selected by not only your peers, but the faculty that you work with to kind of lead and be the liaison between the residents and the training program and the faculty. So it's a pretty nice honor. And he trained under Dr. Scott Schwartz, who is very well known in the community in Michigan for prostate artery embolization, or PAE, and he actually joined us and works with IR Centers. So really, you got some of the best people delivering this care in the community, and Dr. Ogilvie is definitely one of those doctors. So he's excited to come back to, or he's back in Ohio, but excited to be back and offer this treatment to patients. And tonight he's going to go into a little bit more detail about how awesome this new treatment is.
Yeah, thanks, Alex. It's really nice to be here to kind of chat with all you guys again. I'm really excited to be here in the Columbus area and just to be able to offer this as a procedural option under the Central Ohio Urology Group umbrella. You know, certainly it's a comprehensive urology group, and it's just another tool that we have that we can use to treat BPH. So it's really great that we are able to offer that. So just to talk a little bit of background here, obviously we're focusing on prostate artery embolization. That procedure tonight, but just to talk about some of the kind of background info of benign prostate hyperplasia. This is an issue that's very common amongst men, especially as we get older. It's natural that the prostate gets bigger over time as a result of the hormones that our body makes. It's just something that happens in everyone, and it varies from person to person how big the prostate may get. But in a lot of people, the prostate gets big enough that it starts to cause issues, and the reason that is because the prostate is it's in the base of the pelvis. It surrounds the urethra, which is the tube that gets the urine out from the bladder. And so when the prostate gets really big, it can kind of press that tube shut and lead to issues with urine flow, obstruction, weak stream, frequency, urgency, all these type of urinary symptoms that we can see. And so because this is such a common problem, it's something that luckily, there's a lot of different tools we have to treat it. There's a lot of different, options. And so, and there's been a lot of studies on all these different options. So there's different algorithms that we kind of try to follow to really make it the most efficient and the most effective to treat BPH, because one person's prostate that's a certain size is not going to be treated the same as someone else's that's a different size and kind of has different symptoms and things like that. And so whenever we're dealing with kind of how we most effectively treat BPH, we're trying to follow these algorithms and really sort of tailor the treatment that we're doing to the person that we're going to be treating. And so a lot of this is based in scientific evidence. Again, that's kind of a cornerstone of our practice. Just making sure that what we're doing is supported by the evidence that's out there. Again, to make sure that we're doing things that are going to be the safest for folks, the most effective. And then really our kind of specific setup here where I'm offering this prostate artery embolization kind of as a very kind of niche setup with the urology group is really focusing on quality. I'm really here with Coog to focus on this one procedure. Now, there are other procedures that I do there, but the prostate artery embolization is the most common one. And so there is that focus on quality because I'm doing so many of these procedures that I see all the different variations in the anatomy. I kind of know how best to handle different situations. And that really kind of gets you the best experience that you're going to get with this specific procedure, especially. And so just to kind of talk a little bit about the chart on the left here too, while we have this up, and kind of touch on some of the background again, when we're working up benign prostate hyperplasia, some of the things that your urologist may initially do. And again, this is initially going to be dealt with, you're going to see a urologist first, and they're going to do a lot of this workup to kind of determine what treatment's going to be best for you. But some of the things that they might do that I'm sure you've heard of would be like cystoscopy, which is where they're looking, through the urethra with a camera to actually see how things look on the inside. They can tell if the prostate is enlarged and pressing the urethra shut. TRUS, or TRUS, stands for transrectal ultrasound. That's another imaging modality that we use to actually get the overall size of the prostate. So, and that can also assess the shape or morphology of the prostate, which is important in kind of determining what procedure is going to be best for someone. And then the uroflow and the urocuff are additional studies that we can do to look at actual urine flow rates and the pressure that your bladder is able to generate and other things like that. And that's important to differentiate, people that might have urinary symptoms because the bladder is not working correctly versus the prostate causing obstructive issue or something like that. And so basically, you get this workup. Often they'll start with medications for folks because that's kind of the least invasive, safest option to try to manage this. But inevitably over time, medications don't work as well, or the prostate continues to enlarge. And that's where the point where you start to think about needing some type of procedure. And so we have these different kind of flow charts of the different options for procedures based on prostate size and based on whether or not someone is a good candidate to undergo general anesthesia versus just sedation or something like that. And what you'll notice, just to kind of summarize across all the bottom here, is that PAE really kind of fits into most of these categories, or essentially all of these categories. And so that kind of speaks to the versatility of this procedure specifically, that it's able to be useful in a lot of different situations. And that's why it's so important for us to talk about it. And again, this is a common issue. It's over 15 million folks, 15 million men that have, this issue in the States, and have significant urinary symptoms. And, after the medications, when we're talking about doing an actual procedure on the prostate, a lot of the surgeries that the urologists are doing are what are called transurethral procedures, where they're actually, going up through the penis and then working on the inside of the prostate. And that can be a hard sell to a lot of people. Obviously, that's not the easiest thing to kind of wrap your head around having done. And so there's quite a few men that kind of avoid having a type of, one of these procedures done just because of that sort of factor there. So it's something that, again, there's a lot of people that could benefit from procedures that might be avoiding those. And just to kind of touch, again, I sort of group the BPH treatments into two big categories. There's my procedure, the prostate artery embolization, and then there's what we call the minimally invasive surgical therapies. And those are the surgeries that the urologists are doing. And again, their commonality is that they're all working through a transurethral approach, again, meaning that they're going up through the penis with some manner of tool, and then they're working on the inside of the prostate. The most common of these, the one that's been around for the longest, is something called a TURP that you may have heard of, or transurethral resection of the prostate, where they're just going in and they're actually cutting tissue out from the inside of the prostate to try to help open that channel up. There's a lot of newer technologies, though, that they can have that they use. And so in the upper left here, we have something called Urolift that you may have seen. Just to show a brief video on that, basically that's an image of the prostate, and there's a device in the urethra, which is the channel going through the prostate there. And they're essentially kind of pushing the prostate out of the way and using these tethers to try to hold that tissue out of the way to improve the flow through the prostate. Up on the upper right here, we have something called Rezūm, which is another procedure where they again are going in through the urethra, and here they're using a device to actually essentially inject steam into the tissue of the prostate to try to help kill off some of the tissue and kind of cause tissue resorption to open up that channel through the prostate. And then along the bottom here, one of the newer procedures that we have, or that the urologists are doing, through the urethra, is something called aquablation, where they are able to very precisely use ultrasound to actually guide a device that's going in the urethra, and then using a high power water jet to essentially carve tissue out from the prostate from the inside. And so on the right here is kind of what that actually looks like then as that's being done. There's basically a device that's kind of sweeping back and forth, and it's actually cutting the tissue out. So again, these are all great options in the right patient. But they're all requiring that transurethral approach. A lot of these are requiring general anesthesia. They're a bit harder as far as recovery and things like that. And so to kind of compare again, our two big categories of procedure, and then also medical management, which again is going to be the first line. Medical management, while it is the kind of easiest first line treatment that we often do for this, and this is medications like tamsulosin or finasteride or alfuzosin. You may have heard of some of these. They work great in a lot of people, but a lot of these medications are very expensive. Compliance can be an issue. It can be hard to remember to take a medication consistently every day, or something like that. And then a lot of these medications do have side effects too that patients don't like dealing with. Things like sexual dysfunction, especially, is a big one with a number of these medications. And so to talk about, kind of the minimally invasive surgical therapies that the urologists are doing in the middle here, again, these are all being done through that penile route. So they're more invasive than the procedure that we do, the prostate artery embolization, which we'll talk about in more detail in a second here. Although they are still considered minimally invasive because they're not making a big open, incision in the skin or something to do these, but they are, they're a bit more invasive. A lot of these procedures, have higher potential complications because they're in there actually cutting tissue out from the inside of the prostate. There can be issues with bleeding from the prostate, sexual dysfunction, or things like erectile dysfunction or retrograde ejaculation are things that we can see with some of these procedures. But they are, because they're in there actually removing tissue, we do typically kind of view them as having a longer potential effectiveness. Meaning, we see TURP patients that have gone 15 plus years and they've had good relief of symptoms from a well-done TURP. But again, that pro is coming at the cost of the higher, potential complications and things like that. A lot of these surgeries also just require kind of more infrastructure. They're a bit more involved, but they require general anesthesia. They have to be done in a hospital or potentially an ambulatory surgery center or something like that. But that still is just kind of a more involved process to go through one of those. And then finally, our procedure to start to get to the prostate embolization, it really is the least invasive option that we have to try to treat the prostate. We're coming at the prostate from a completely different approach, which we'll talk about in a second here. But what we're doing is office-based, meaning, I'm not working out of a hospital. I'm actually just in a medical office building, so it's easy in, easy out. The effectiveness of our procedure is actually, the duration of symptoms is very good. It's comparable to a lot of the other procedures that the urologists actually do. And so, it's well, it may be a bit shorter than something like a TURP, in general, when you're kind of comparing them as far as how long you expect the symptomatic relief to last. It is still a good result, and we'll talk more about that in a second here. And we really have very, very low risks of any kind of sexual side effects. We're not going up through the penis at all to do this procedure, and so there's a lot less discomfort after the procedure. And there's some other advantages, like that we don't have enough. We have kind of fewer limits on what size prostate glands we can actually treat with our procedure, which I'll talk about a bit more in a second here. And again, this is just kind of summarizing some of the specific treatments. Again, the PAE is the one that we're here to talk about today, but the TURP, the Urolift, Rezūm, aquablation, those are all the procedures that the urologists are doing. But the PAE, again, it's a really nice minimally invasive option to treat the prostate that a lot of people, deserve to know about because it may be a good option for them. So actually then kind of talk about sort of what are we doing then for prostate embolization? So how is this so different from the other procedures that the urologists have traditionally done? So we're really coming at the prostate from a totally different viewpoint. We're actually purposefully trying to cut down the blood supply to the prostate. And we can do that by just working through a single needle poke. And when I do this procedure, I go through the right femoral artery, which is an artery that we can see well with ultrasound where the leg meets the pelvis in the right groin area. I'm able to use ultrasound to guide a small needle into that artery. And then I can use an X-ray to watch as I pass a really long but really small diameter wire or an tube or catheter and kind of snake up through that artery, then up into the pelvis. It's basically like a fancy version of plumbing that I'm doing. And that's kind of what this video is demonstrating, is my little catheter and my little wire kind of moving through the arteries inside. And again, we're using X-ray. We basically have a live X-ray video feed to watch as we're moving this little wire and catheter through the arteries. I'm injecting contrast as well into the arteries every so often, and that lets me kind of map out how they're branching around the pelvis and basically figure out what arteries are going where. So I get in there, I map out all the arteries in the pelvis, and my goal then is to find the arteries that supply the prostate gland so that I can get my little catheter, which again is this blue thing here, get that into that specific artery that's going to the prostate, and then purposefully cut down the blood supply through that artery. The way that we typically do that is by injecting small particles or beads, which is what this is kind of demonstrating here. They're actually made of a medical grade plastic, and they essentially go in these little tiny arteries as they enter the prostate. They're too big to fit through the prostate itself, and so they get lodged in place, and that's what's actually cutting down the blood supply to the prostate. When we do this, we cut down the blood supply like that, we expect that we're basically starving the prostate. It's not getting the oxygen and nutrients that it needs to survive. So a lot of the cells within the prostate gland will die off and they get cleared out by our immune system, and that actually leads to the prostate shrinking down in size. And over on the right here, you can see a picture of, I believe this is probably from an animal model, but a normal prostate versus one that has been embolized. You can see that it's a lot smaller, after it had been treated like that. And so this is just another image of kind of what I'm actually seeing as I'm doing the procedure. Again, this is after I've gotten into the artery, and this is kind of what my X-ray video feed looks like. And this video plays really fast, but basically I'm in there, and I'll try to pause it here, and I'm injecting the contrast through that catheter, which is in the artery. And so that black is the contrast going into the arteries and kind of giving me this map of where the arteries flow around the pelvis. And so I'm looking for a specific artery, which is this kind of real curvy one here, but we can pretty reliably find this artery that goes to the prostate and then get into that and block it off from the inside. So to kind of talk about who the best candidates are for prostate artery embolization, kind of the most common or sort of general indication to have this done is going to be someone that has moderate to severe lower urinary tract symptoms. So issues with like frequency, urgency, incomplete emptying of urine, weak stream, all these kind of things. Someone that has bad symptoms related to their prostate being enlarged, and they've often tried medical management first, and that medical management has failed for whatever reason, whether the medications just didn't work or they had side effects that were intolerable. And when we're looking then, at who's going to be a good candidate, we always like to know the size of the prostate that we're treating. Because I'm going in there and trying to get into these arteries, we actually like when the prostate is bigger, because the bigger the prostate is, the bigger the arteries often are that go to the prostate. That makes it easier for us to do our procedure. It's easier for us to see the artery, easier for us to get into it to actually then block it off. And so we do kind of put a minimum typically on the size of prostates that we'll treat, because below a certain size, we know that these arteries are going to be very small, and it can be difficult for us to actually get into them and complete the treatment the way that we want to. On the flip side, though, we really don't have a maximum size of gland, which is a big advantage of our procedure versus a lot of the other surgeries that the urologists do. They kind of cap out at a certain size, and if it's bigger than that, it's hard for them to work from the inside of the prostate and actually successfully achieve their procedure. Whereas, again, we're just treating these arteries, and so it's almost better the bigger the prostate is for us to complete the procedure. There's a number of other situations that arise depending on specific circumstances for which prostate artery embolization might be a good treatment, especially the big ones. If someone has bleeding from the prostate, which can happen spontaneously from benign prostate enlargement. If the prostate's very big, sometimes the tissue actually breaks down kind of on its own, and it can ooze and cause bleeding issues. And so obviously by us going in and blocking the artery off, that can directly help out that bleeding. We can do this as a combination with some other surgeries. So the aquablation specifically, that procedure where the urologists are going in and using the high-power water jet to actually clear tissue out from the prostate, that procedure has a relatively high risk of bleeding, especially on very big prostates. And so often for those types of surgeries, they'll actually have us do a prostate embolization first to reduce the blood supply to the prostate before then undergoing that aquablation surgery. And there's other things, for people that, like we said, have failed, or some people just don't like being on medications, and that's reasonable. That's a choice that people can make. And so if they don't want to take the medications, they may want to move straight to a procedure. Patients that get stuck with a catheter because the prostate's so big that it's actually completely blocking the flow of urine off. And so they need something done to actually go in and kind of restore that flow so they can get rid of the catheter. That's another situation. But in short, there's a lot of different scenarios where our procedure really works well for patients and is a good option because of how safe and minimally invasive it is. So basic statistics, just as far as how effective this procedure is. At this point, PAE has been around for 15 plus years. There is a lot of data, backing up the efficacy of this procedure. And so what we typically see in patients that are a good candidate for having this procedure done, 85 to 90% of patients are going to end up having significant symptomatic improvement after undergoing this procedure. And that is comparable with a lot of the other minimally invasive surgeries that the urologists are doing, like TURP and Rezūm and HoLEP and all those kind of things. One downside of our procedure is that it does take some time to actually work after undergoing the procedure. Often it's about 3 weeks on average once we've done the procedure that it may take before people really start to notice that things are improving. And that's just a natural result of how long, when we block the arteries, it just takes that long for the prostate to really start shrinking down. It's not an immediate effect that happens. Studies have been done over time, kind of looking at exactly how much the prostate size changes after we block the arteries. I don't want to get too much kind of focused on the size part of it. We've seen that studies have shown on average it's around 30, maybe 40% size decrease that we'll see when we block these arteries off. So it's not going to totally kill the prostate. But the overall size of the prostate is not the only factor here. There's also other theories about softening of tissue or versus the stiffness of the tissue of the prostate and other things that kind of make it a bit more complex than just looking at the size. But we have at least seen that when we do this procedure, there's a 30% decrease in size. And that, again, goes along with a significant symptomatic improvement in a lot of people. And like I was kind of talking about before, this procedure, because, we're not totally killing the prostate, we do kind of put a time limit on how long we expect it to be effective. On average, people that get good results initially from this procedure will go 5 to 7 years before they might have recurrence of symptoms that is similar to what they had before undergoing the procedure. And that, again, that time frame is maybe a little bit shorter than some of the other procedures, like a TURP or something, depending on kind of what source you're looking at and things like that. But it's a trade-off, right? Our procedure is the least invasive. The recovery is a lot easier. There's a lot of other advantages versus a TURP. So a TURP is a little bit more aggressive, but it potentially could get you longer benefits. And that's something that, when you're kind of talking with myself or with your urologist, you kind of just have to discuss if you're sort of deciding between the two. An important thing to note, though, is that while our procedure may have kind of a time limit, we can actually repeat it. We can go back in and do it again. If people have symptoms come back, we can go in again and repeat treatment. So it is, it's not just a one time and you're done kind of thing. So that's good to know. When we're following these patients, obviously we're talking to them when we're asking about symptoms and kind of seeing how things are going. We do try to kind of quantify people's symptoms, and we do that using something called an IPSS score, if you've heard of that before. And that consists of a questionnaire that we'll have patients do before undergoing our procedure, and then we check it at certain time intervals after undergoing the procedure to kind of monitor their progress. So we try to, again, quantify or try to actually put a number on kind of how much your symptoms are improving. But just to give you sort of a sense of what results we're seeing, that IPSS score can range from 0 to 35, and 0 is no urinary symptoms at all, whereas 35 is like the most severe, kind of urinary frequency, urgency, weak stream, all that kind of stuff you can imagine. Our data specifically, which we do, track internally in our office, we've seen amongst all of our 4-week follow-up patients, which is the first follow-up that we do after this procedure, we see an average of a decrease of that score by 11.4 points, which, again, the difference from mild to moderate to severe, it's roughly, kind of about 10 points in each of those. And so, that's going from moderate symptoms to mild symptoms, and that's just at 4 weeks. And we expect symptoms to continue to improve actually for several months after the procedure. That may be how long it takes for the prostate to actually shrink down as much as it's going to. And so while that's just at 4 weeks, we think, for most people, as you give it more time, they continue to see even more improvement. And so that's sort of, again, just trying to put a number on kind of the actual symptomatic improvement that we're seeing. To go into a little bit of detail about what to expect, when you're undergoing this procedure, it is all a same-day procedure. We do this out of a medical office building like we talked about. You're with us for about 4 hours total to get this done, of which the procedure takes about 1 hour to actually complete. Occasionally it can take a bit longer if someone has difficult anatomy or something like that, but by and far the most procedures are done in about an hour or so. This procedure we do with sedation. We don't do it with general anesthesia. The reason, and just to kind of differentiate, so general anesthesia would be putting a breathing tube down, giving you medications that completely knock you out where you're not breathing on your own. That's what you undergo when you undergo a surgery or something like that. Whereas the sedation that we're doing is similar to colonoscopy. It's those twilight medications that make you feel drowsy as we're working. And we do it with sedation. Number one, the main reason is that it's a lot safer. It's a lot lower risk than general anesthesia. You wake up, after the procedure, the sedation wears off and you're fine. You don't have to go through that period of being super groggy that you may know of, if you've undergone general anesthesia before, that kind of thing. And so the recovery is a lot faster. Again, we're getting you out, 2 hours after the procedure is over generally. So And really, we can do this with just sedation because the procedure is not very painful. I only really cause pain at one point during the procedure. It's when I give numbing medication right at the very beginning of the procedure. Before I do that needle puncture into the femoral artery that I start with, I do give some local anesthesia that stings and burns for about 10 or 15 seconds. But after that, I don't expect anything that I'm doing inside of the body to be painful. You don't feel as I'm moving that little wire and catheter along the inside of the artery. The one thing that you may feel is occasional warmth or heat when I inject the contrast into the arteries, but that's a normal sensation that the body has, and that should not be painful. You may know what that feels like if you've ever had a CT scan done with contrast before. There's kind of this feeling of warmth, but it's really the only thing that indicates that I'm in there actually doing anything as I'm doing the procedure. So it really is, I've had a lot of patients kind of, we're in there, I'm working for 10 minutes and they're like, have you even started yet? And I was like, yep, we're in there, mapping things out. It really is that painless. So once we've completed the procedure, there is a 2-hour recovery period. And we have you on bed rest laying flat, basically just to help that artery puncture site heal up. We do use a special device to close that little hole in the artery at the end of the procedure. And so we want that to heal up well. But after that 2-hour period, you can get up and walk around. And basically you just go home and take it easy. More recovery kind of than getting, what happens after you get home. We do always have an activity restriction on people because we're doing that femoral artery puncture where we want you to avoid heavy lifting for 5 days. That's really the big one, just so that you're not straining the muscles in the area where that artery is to potentially cause it to start leaking or something like that. So you do have to take it easy, but you can still walk around and do other, any kind of light activity like normal is fine. Other important things, you can shower the day after the procedure. You can drive the day after the procedure. Really you can get back to doing most of your normal things other than heavy lifting pretty quickly. The other big recovery related thing that we always talk about whenever we do this procedure is that when we block the arteries off that go to the prostate, we expect that we're going to temporarily cause inflammation in the prostate. This is a normal response that the body has. Basically, it doesn't like very much that we've cut down the blood supply there. And so the immune system kicks in. The prostate actually swells up a little bit. And when it swells, it's temporarily getting bigger. This is temporary. That's the important thing to keep in mind. But it gets a little bit bigger. And so whatever your normal urinary symptoms are, because the prostate is enlarged, I expect actually will initially get worse immediately after the procedure. Typically, we see that these symptoms are kind of the worst around days 3 to 5 after the procedure. It's improving for most people by a week after the procedure and essentially resolved by 2 weeks after the procedure. But everyone's a bit different. Some people have more dramatic temporary inflammation symptoms than others. But that's, again, kind of what we normally expect to happen. We do start everyone that we do this procedure on a standard regimen of several medications to help reduce that inflammation. So we do try to stay on top of those symptoms and get you through that. And for the most part, it's just kind of giving it time. Again, this inflammation happens, but it goes away on its own and things get back to baseline. Again, and then it might be about 3 weeks on average before you start to really notice that things are improving as far as your urination goes. And so this is kind of just a curve sort of demonstrating what we expect as far as, your urinary symptoms after the procedure. We do the procedure, that's the baseline. And then there's this short-term worsening of symptoms because of the inflammation that happens, but then things get back to baseline and then they just continue to improve from there. And again, it's about 3 weeks on average before people start to really notice that there's been improvement. And it may take several months, even out to like 4 or 5 months before you really get all of the benefit that you're going to get from this procedure. So, to finally kind of touch up on some of the risks, this is always kind of the last thing I talk about when I'm having a consult with patients, because obviously we want to make sure that you know what you're getting into. These risks are things that I think are very, very unlikely to happen, but we always just have to bring up so that people are informed. This procedure, again, the hallmark of this procedure is that it's the least invasive option that we have to treat the prostate, and so it really is exceptionally safe. The sedation that we're using is a lot safer on the body and easier on the body than general anesthesia, so that's one of the big advantages. We avoid those risks of general anesthesia. In theory, the prostate, when it undergoes that inflammation right after having the procedure done, it's possible that it could swell enough that it puts you into what's called retention, where you're unable to urinate. Because it's swollen so much, your bladder just can't get the urine out. That's something that is very, very rare after this procedure. We do not, and this is important for patients to know, we do not routinely place catheters in patients when we do these because we expect that this risk of going into retention is exceptionally rare. There are some cases where we might talk about placing a catheter with this procedure in specific circumstances, but by and large, we're not placing catheters in most patients. So that's something that's important to know. And that's another big difference when you compare to other urologic procedures like TURP or or some of those other ones, often, you know, you're going to have a catheter for at least a couple of days, you know, after undergoing one of those types of procedures. But with ours, typically we can avoid that. Bleeding with our procedure is very, very rare. We're working through a very small hole in the artery, and we make our needle puncture somewhere that we can easily hold pressure over if we need to. So it's extremely unlikely that we have any kind of uncontrolled bleeding from the artery or something at our access. You know, the thing I always mention to people is that there is a very small risk that you could develop what's called a hematoma at that access site after the procedure. That risk is about 1% or less. And that's where, when I close that little hole in the artery, it's possible that there's a slow leak that I don't pick up on right away, or that develops after you leave our office. And that could allow blood to kind of collect around the artery, but under the skin. It's a really slow leak, but it's enough to allow that blood to collect, and that can cause swelling, bruising, pain. It is something that, you know, we keep a close eye on to make sure that it's not getting bigger over time, but your body will absorb that hematoma over time. It is something that does heal as long as that leak is not still ongoing. Infection with this procedure is very rare because we do everything with sterile technique, and we do place patients on antibiotics when we do the procedure. So it's very, very uncommon that we introduce any type of bacteria and cause an infection with this. And then finally, the last thing I always talk about, you know, when I'm in there mapping these arteries out, we can be extremely precise with how we're identifying the arteries and kind of selecting them before we start blocking them off. All these arteries have very characteristic appearances. It's, you know, easy for us to identify that the artery is going to the prostate. We can make sure that there's not big supply to other structures around the pelvis. And in doing so, we make sure that it's very safe. When we start actually blocking the artery off, the chances that we inadvertently block supply to something we don't want to treat are exceptionally low. This is important because our procedure really has the lowest incidence of any kind of sexual side effects, you know, of any of the interventions that we do for benign prostate hyperplasia, especially compared to TURP and some of those other transurethral procedures where sexual side effects are not uncommon. They're really very rare with our procedure, and there are arteries around the pelvis, of course, that are responsible for things like having erections and whatnot. But when we're identifying these arteries and mapping everything out, again, we make sure that those arteries are not going to be in the area where we're blocking the flow off. And so that way we can really, you know, avoid that kind of thing from happening. So we do have, you know, if you're following with our urologists here, we do have educational materials in the office. So certainly, you know, if you talk to your urologist and you're interested in having this type of procedure done, definitely kind of ask them if they can give you this brochure. We do have some brochures that summarize some of this data as well. You know, if you want to touch up on that when you're following up with folks. So just wanted to mention that real quick. I think we kind of already talked about that. So I think that kind of summarizes most of what I wanted to go over as far as just introducing prostate artery embolization and kind of how it fits into the treatment algorithm for BPH. I think at this point we were going to address questions if we have some from the chat. I know I think we're encouraging people, if you guys have questions that you want to ask myself or Dr. Puidafa, please put them in our chat, and we can look at them and try to answer them as those come up.
Thanks a lot, Dr. Ogilvie. I actually was answering a lot of the questions while you were talking, because the questions were coming across. But I can kind of go through. I answered them in the chat, everyone can see, but I can kind of run through some of them that we've gotten. So, does this affect the two nerves for ED? And what about if you have a cancerous lesion, or what if you have cancer? So with the ED, no impact on erectile function at all. It will not improve your erectile function, but it's not going to make it any worse. This treatment does not actually impact cancer in a negative way, so it will not make your risk for cancer higher. If you have cancer, it will not cause the cancer to progress. But we cannot say that it makes it better. We just know we can say it's not going to make it worse. And they were asking about the sedation. We talked about moderate sedation.
Sorry, can I interrupt real quick?
Absolutely, go for it.
Well, you're to just go back to the erectile dysfunction question. I guess I will mention that there can be the indirect improvement if you're on like a medication that is causing side effects, like you know, some people that are on finasteride or something that's causing erectile dysfunction. If you're able to come off those medications, which is a reasonable goal undergoing this procedure, some people are able to come off of some of those prostate meds if their symptoms improve enough. That is an indirect way that it could improve your erectile or general sexual function. I was going to mention that.
Absolutely, yeah, that's a great point. So yeah, most men, like Dr. Ogilvie said, are able to come off of their prostate medications, which some of the known side effects of some of them can be retrograde ejaculation or issues with libido. So yes, that's a great point. Someone asked, it's the same discomfort level as cystoscopy. The procedure itself, it will not be the same level as the cystoscopy. There's not really much discomfort at all. As Dr. Ogilvie said, it's really just that one pinch up in the beginning where you just get that numbing at the top of the leg. After that, there's really no pain. One person asked, how does PAE affect your PSA levels? So PSA actually, and Dr. Ogilvie did a good job explaining about that post-embolic part of the after the procedure recovery period, where you actually have that increased frequency because of the swelling of the prostate actually is inflamed or swells up before it shrinks. The PSA will actually go up. The prostate will leak PSA, so actually go up and spike in the first couple of weeks, but it will reach a new steady state that will be a fraction of what the baseline PSA is. Probably reach that new steady state in about 3 months. Someone asked, can you have a PAE after Urolift? No other prior treatment for your prostate would preclude you from having a PAE, including Urolift. Is there an age limit? No, there's no age limit. How about insurance coverage, specifically Medicare? Medicare covers PAE, and most private insurance companies coverage will, or insurers will cover the procedure. Looks like we got a few new ones in here. Let's see. What costs? Okay, so we talked about that. The fact that it kills parts. So yeah, so someone wrote the fact that PAE kills part of the prostate concerns me. Sounds like a risk. I mean, so right now the prostate's overgrown, and really what it's causing is shrinkage. So some of the cells that, like Dr. Ogilvie was saying, it's going to just reabsorb, but the rest of it will actually just like shrink. It's overgrown. It's going to shrink. Someone said, what if you were on Eliquis? So this procedure can be done on Eliquis. We prefer patients to hold it for 48 hours if they can.
Yeah, it's another real nice use case for our procedure. Really, we have the lowest bleeding risk. Even though we're working through an artery puncture, we're making an artery puncture in a very controlled way. And so a lot of the urologists will be hesitant to do any of those types of surgeries where they're in there actually cutting tissue out of the prostate on someone that's on a blood thinner because of the risk of bleeding from the prostate. But the bleeding risk from our artery puncture is exceptionally low. And then we're otherwise, cutting down the blood supply to the prostate is the way that our procedure works. And so since we have very good devices to close that little hole in the artery, we don't have the same limitations as far as blood thinning medications in general and that kind of thing. So there are a lot of patients that might not be surgical candidates because they're on a blood thinner or something that can still undergo a prostate embolization. So that's another nice use case for it.
Right. Yeah, no, that's a great point. Other people are asking about like issues of prostate function afterwards. It's not going to impact prostate function. Doesn't significantly. So prostate can help produce some of the fluid for semen. No real significant impact on that at all. You may see blood in the semen transiently for a couple of weeks after the procedure, but that's a small percentage of patients who are self-resolve. Other people are asking about insurance coverage. How would it be billed? Someone's asking. So we have once Dr. Ogilvie does the consult and the scheduler gets you on the schedule. We have a team that will work in the background that will interface with your insurance company, so they'll make sure it gets covered, and you'll know what, if anything, you would owe prior to coming for the procedure. So we can take care of all that for you. I think that's going to cover most of these questions that are in this chat. Are there any activities you should avoid after the procedure? Yeah, I think Dr. Ogilvie touched on that. But yeah, no strenuous activity, no heavy lifting for 5 days. And that's not really the procedure itself or the embolization of the prostate itself. It's more so just that access site that he's going to close up. So it's really out of abundance of caution, but for that site to heal up. But 5 days is what we typically recommend. So now we're getting some individual situations here, which I would encourage you guys to reach out to set up a consult, and Dr. Ogilvie can go through these individual cases with you, and he's very meticulous and detailed, and I'll have all that information up front and can tell you more about the procedure. But
yeah. Let's say just to kind of go into that, yeah. If this is something that you're interested in, which again, this is it is a very versatile procedure. There's a lot of patients out there I think that can benefit from it, and it is again just to not to harp on it, but it's really the least invasive option that we have to treat the prostate. It does get very good results, comparable to a lot of the other surgeries that the urologists do. So certainly don't hesitate to reach out to us or to reach out to your Central Ohio Urology Group urologist. They can, I am an employee of the urology group, so everything's internal. They can easily refer you to me if you're interested in this. And whenever we're talking about this procedure, I always do a consult ahead of time just to review specific cases. I'm going to look up, your case. I'll look up all your data as far as your size of the prostate and what workup you've had done and all that kind of stuff. And so we do spend time talking. Typically consults are about half an hour. We spend a lot of time talking about your specific case and kind of what expectations are and if there's anything that's different than kind of what we typically might expect, we talk about at that point. So it is, it's not something that you just show up and suddenly have a procedure done. Certainly we're more than happy to kind of review all the specific cases if you get to us for a consult. So
all right, great. Thank you, Dr. Ogilvie. Thank you everyone for attending. And this is recorded, so you want a copy, I think it can be sent out as well.
Yeah, I think these are going to be automatically sent to everyone that had signed up for the webinar. So that video will be there for you to review. But again, don't hesitate to reach out to us if you have additional questions that you'd like to speak out to us directly. Okay, I think that's gonna do it then.
Thank you. Good night, everyone.
All right, good night, guys.